Life is basically transfer of energy from the sun to biological beings, squirrels, humans, and the carrier of that energy is NAD in biological systems.
Carrier of the high energy electrons.
The high energy electrons is what is fueling growth, repair. Every biological process basically is fueled by these high energy electrons. Moving these electrons around to where they need to go is the function of basically NAD, NADP, NADH.
These high energy electron carriers are really the central catalyst of life.
How does NAD kind of carry these electrons through the mitochondrial process? Dr. Brenner, thank you for joining me today.
My pleasure.
Yeah, I'm really excited about this conversation because, man, there's this huge world of NAD that everyone is talking about. Seems like the topic of conversation and the longevity space, I'm doing air quotes, longevity, but also just health span in general. A lot of people are talking about it. And I feel like a lot of it started with you.
Yeah, I guess so. I mean, NAD has been a thing in biochemistry for 100 years or more. It's the central electron carrier in biology, right? So I was just explaining to my stepsons, how does a biological stuff work, right? Are humans like perpetual motion machines? Do we violate the second law of thermodynamics? And the answer is no, we don't violate the second law. The second law says that in a closed system, things become more chaotic, right? Everything falls apart, right? And like you when you break an egg, it's broken and you can't get it back together. Humpty Dumpty problem, right? But then you can go look out in nature and you can see a squirrel in your yard, and you saw it when it was a tiny little squirrel.
That's true.
And let's say it had 100,000 brain connections, and then it becomes a full-grown squirrel, and it's like 4 times as big, and it has 1,000,000 times as many brain connections. So it seems like it's going in the direction of becoming more orderly, right? So how is it possible?
Right.
And the reason it's possible is that there's a sun 93 million miles away, and the sun is hitting the earth and making green plants. And then the squirrel and we are either eating those plants or we're eating the squirrel that ate those plants, right?
Yes.
We're taking energy into our bodies.
Yes.
And then the carrier of the high energy electrons are NAD coenzymes. And that allows us to keep our S together, keep our stuff together, and oppose all of the chaos and oppose the disorder of the universe and, be healthy and live our lives.
I mean, there's such a beautiful explanation of it because, life is basically transfer of energy from the sun to biological beings, squirrels, humans, and the carrier of that energy is NAD in biological systems.
Carrier of the high energy electrons.
Right, exactly. And so the high energy electrons is what is fueling growth, repair. Every biological process basically is fueled by these high energy electrons. So NAD on a biochemistry level is what's carrying those electrons from place to place where they need to go, right? And much of this process occurs in an organelle called the mitochondria, right? So how does this all fit together? How does NAD kind of carry these electrons through the mitochondrial process?
So when all of your cells take in fuel, right? So they're taking in protein, fat, or carbohydrate, right? Those are the 3 things that have calories. That's the stuff that fuels our body.
Right.
We have some micronutrients as well. NAD is a micronutrient, but it's protein, fat, and carbohydrate are the energy-containing components of our food, and carbohydrate. And, I'm not anti-carbohydrate. I'm married to a runner. And, we have 5 millimolar glucose in our body, right?
Sure.
And even if you don't eat carbohydrate, your body is going to make it, right? And you can healthily eat carbohydrate. But when the carbohydrate oxidation occurs in what's called the cytoplasm.
Right. The inside of the cell.
But the high energy electrons have to be transferred into the mitochondria to make ATP. But then some of the high energy electrons get put onto a molecule called NADP, forming NADPH, and that's how you make lipids, that's how you make nucleotides, right? And so we have to make all of our own DNA and RNA. We have to repair all of our nucleic acids. When you cut yourself, you have to make more cells. You have to make lipids.
Yeah.
That depends on NADPH. So these high energy electron carriers are really the central catalyst of life.
Yeah. And so moving these electrons around to where they need to go is the function of basically NAD, NADP, NADH, right? Yeah. And once they get into the mitochondria, your mitochondria puts them through a process to make ATP. And ATP is the energy molecule that fuels basically everything else.
So there's this exchange system where you can use high energy, and now we would need a whiteboard, right, to do the whole, because there's proton pumping and there's multiple electron carriers. But the key is that the highest energy electron carrier is NAD, forming NADH, and then it initiates what's called the electron transfer chain, the end result of which is production of ATP, and then then you can flex your muscles and you can record an event and create a memory and do all the things that you need to do.
Yeah, exactly. And so my point of this is really just the importance of NAD in our biological systems. I think it's an understatement to say that without NAD we couldn't live, obviously, but everything depends on NAD. And how did we come from, I mean, we've known about NAD, like you said, for decades.
Yeah.
How do we come from just as, something being taught in biology class at high school to where we are now, where, NAD is really being looked at as something that people can take, right, as a supplement, is being looked at in many disease states as a problem if you don't have enough NAD.
Right.
And in many other branches of science where we're looking at NAD to improve performance, improve athletic performance, et cetera. Like, what happened?
Right. And the fact that there's a mechanism requiring NAD, that's important. Yeah. But that doesn't necessitate NAD as a supplement. What really necessitates NAD precursors as supplements is the fact that the NAD system comes under attack, right? So, for example, I could explain to you that neurons firing requires sodium, but that doesn't mean that we need more salt in our diet. Right?
Exactly.
I mean, there are people that will sell you more salt in your diet, but I don't think they should, right? I mean, we're going to have a blood pressure problem if everybody adds a gram of sodium chloride to their diet.
Well, people are now, people are selling packets of electrolytes every morning.
You and I are not among them.
Yes.
But so just because there's a mechanism involving NAD, that's not the use case for the supplement. What we found when we started looking at the NAD system is that there's many conditions of metabolic stress in which the NAD system comes under attack, right? So, for example, we found when we made mice fat, so we call it overnutrition, right? It's a nutritional problem by having too much food.
Right.
And so you put mice in, small cages with a high-fat diet, and they become really fat, and you can push them over into type 2 diabetes, and their liver NAD system goes into decline. We looked at, that's a mouse result, but then we looked at humans with alcoholic liver disease, and their NAD system is under attack. When you and I were just outside in the oxygen and the sunlight, both of which are lovely. I mean, we can't live without oxygen, and it's not pleasant to live without sunlight. And ultraviolet, rays will, hit our DNA and will cross-link thymidines and create, a type of DNA damage. And when that DNA damage is repaired you use NAD.
You're right.
So in oxidative stress, you churn NADPH. In DNA repair, you use NAD. When our bodies come across things are recognized in the innate immune system, like viruses,
Yeah.
right? We have some enzymes called PARPs, and the PARPs get angry and activated, and they start churning NAD. So it turns out that inflammation and virus exposure causes use of NAD.
Right.
And cell division, you require NADPH. So there's many conditions of metabolic, and then disease processes. Like in heart failure, there's a specific attack on the NAD system. In different kinds of central and peripheral neurodegeneration, there's an attack on the NAD system. So it turns out that NR, and to some degree the other NAD precursors like niacin or nicotinamide, can support NAD metabolism and support resiliency in face of metabolic stress.
Got it.
So I kind of wish that the clinical trialing thing didn't start out with the presumption of like lifespan, because you can't actually measure that. Right. So you can measure some biomarkers, but I don't think it's that interesting.
Right.
But when you look at like there's now 8 completed randomized clinical trials that show that NR lowers inflammation.
That's amazing.
Right? And inflammation is one of those fundamental components of disease processes. It's related to the lack of capacity that we get to in our dotage as we age, right? And so you want anti-inflammatory. So I prefer that we do the clinical trials for those really clear endpoints, right?
Right. We
because
can measure.
You can prove it.
Yes,
right?
yes.
And then there's a positive one for peripheral artery disease, right?
Okay.
Where if you take care of people with peripheral artery disease, you do a 3 or 6 month trial, their walking speed is going to be demonstrably less at the end of the trial.
Right.
If they're in the placebo arm.
Right.
And there was a completed trial, University of Florida and Northwestern University. I was not involved in it. And it showed that the people on a gram of NR a day had improved walking speed.
That's incredible.
Right? And placebo was degraded walking speed.
So it did degrade with the placebo.
It degraded with placebo because they have peripheral artery disease.
Right, exactly.
And, it's a strong enough result that they're going to do, I think, a phase 3, to really... I mean, these are establishing use cases for NR, right? So generally, I think probably your patients are taking it in the context of wellness, right? Disease prevention, wellness, and it says on the bottle, not to,
not to treat any disease, because you have to say that, right?
Yeah. But the use case is that it actually controls inflammation, and it supports resiliency because it. Whether or not we have alcoholic liver disease or suffer from, overnutrition, which you and I don't, we are exposed to viruses. We are exposed to things that challenge our NAD system.
Yeah. So when you say the NAD system is under attack, it's being forced to work harder than our human biology has ever needed to work for overnutrition, for toxic exposure, or
humans are amazing at aging.
Yeah.
Right? Humans, like gorillas are bigger than humans, and generally longevity scales with animal size, right?
Right.
And like whales and sharks live a super long time. I mean, not the smallest sharks, the biggest sharks do. And but gorillas are bigger than humans.
They are,
But, they live maybe, 4 decades or something like that. And we live 8, 9 decades.
Right.
Some people 10, 11 decades.
Right.
Right. So humans are really good at aging if you don't have the accidents and you don't have polypharmacy and you don't do all the bad things. Humans can live a long time. So, but I think that, but you can just observe that when somebody who's 10 falls off their bike, right, and gets some scrapes, they repair really rapidly.
Right.
When somebody who is in their 7th or 8th decade, if they're still riding a bike, that's great. But when they fall off their bike, when they're 80 years old, those scrapes don't don't heal very, very rapidly, right? So we want to support that healing process. That's actually another clinical trial I'd like to see done, is the wound healing as a function of age, right?
Or surgical, pre-surgical and post-surgical NAD. Yeah, that's a great clinical trial. In my previous life, I did surgery, and so anything that you could do to accelerate wound healing is monumentally important. So that's a great idea for a clinical trial, for sure.
Yeah.
So, okay, so you found this molecule, NR, right? Nicotinamide riboside.
Yeah.
And since then, there's been other permutations of these that have been talked about. NAD, NMN, right? Then we also have niacin, right? Can you kind of tell us the difference between this whole world of molecules that people hear about?
Yeah. So NAD, NADH, NADP, and NADPH have 2 or 3 phosphates on them.
Right.
Which are 2 or 3 phosphates too many to get into any cell.
Right.
Right. So, like if there are docs out there that treat cancer patients or docs that prescribe antivirals, there are cancer drugs and antivirals that are in the class of molecules called nucleosides. They're all active as nucleotides. And the difference between a nucleoside and a nucleotide is phosphates.
Right.
Right. So, like there used to be a compound for AIDS, HIV called AZT.
Right.
And you give AZT, and then it would get into cells, and then inside the cells it would turn into AZT triphosphate. Okay. So NAD is the great stuff, but if you inject it or if you eat it, and it's in food, right?
Right.
Because the squirrel that's eating the plant matter, or us that's eating the squirrel or the cow, we're eating cellular stuff, and so all that cellular stuff has NAD in it, right? But in the digestive process, the phosphates basically get taken off.
Right.
The biggest piece of NAD that can get into cells is NR. Right. This is the thing that we discovered in 2004. We discovered nicotinamide riboside as a vitamin precursor of NAD.
Can I just add one thing to that? So the phosphates, the reason NAD connected to a phosphate does not get into a cell is because every cell has a phospholipid bilayer. And so phosphates bang up against phosphates and they can't get through.
Yeah,
right? It's like basically a wall against a wall.
What's a repulsive explanation that you just gave, Dr. Shah. But that's exactly right. I mean, there's like negative charges and there's a negative charge on the membrane and it doesn't work that way.
Right. So the NR can get in because there's no phosphate on it.
Right. It's not charged.
Right. And bring this, to bring this to practicality, you feel this when you're doing IV NAD versus IV nicotinamide riboside, because IV NAD hangs out in your bloodstream for such a long time. Has to break down, and it feels miserable. It takes a long time to do these
You know why
IVs.
it feels miserable? I think it feels miserable because there's an innate immune reaction to NAD. NAD is supposed to be an intracellular molecule, just like mitochondria are supposed to be inside cells.
Right.
Long chromosomal DNA is supposed to be inside of cells. When cells burst open, there's long chromosomal DNA, mitochondria, NAD itself, and ATP, and all of those things will activate the innate immune system.
Got it.
You get an inflammatory reaction, so people feel hot, right?
Right.
Yeah. So, so when people are doing an intravenous NAD injection, and I learned that was a thing from watching Billions. Like a few years ago, they were
the show.
Yeah, they were showing Billions, and people were like the stockbrokers or whatever, or have a long night of drinking and doing drugs, or and they would call up a nurse and they would get IV drip, right?
Yeah.
And so people have been doing this for decades, as it turns out, and saying, well, I feel great at the end of this, but miserable during it, and that's what you're talking about.
Yeah,
so then, when I literally had this conversation with the CEO of Chromadex, And, he asked, well, could you deliver nicotinamide riboside? And what would be the expectation? And I said, well, the expectation is that it would not be painful.
Right.
And it could probably be delivered more rapidly. That's now been demonstrated in people. And so that's a great thing. Now, what's the use case exactly for, IV NR rather than oral NR? I'm going to be honest with you and say it's not really been demonstrated. You have people at the leading edge, right?
Yeah.
That are like performance-oriented people, athletes, and so forth. They're saying, for recovery, they feel great when they do an IV NR, but it's only now that there is clinical grade material from which you can do clinical trials.
Right.
With NR, the clinical grade oral NR was available now for more than 10 years, right? Which is why we can now say that, it's active in anti-inflammation, it's active in peripheral artery disease. So I'm hoping that, in the future, that there will be placebo-controlled trials that will test some of the things that people are claiming about IV NR, like potentially lowering their urge for drugs. Like I've heard that, that it may have activity in opioid
There's a lot of
addiction,
recovery centers using it. Yeah, absolutely, yeah.
And so when I've suggested to people that are running those recovery centers that they do a trial, even a crossover trial, where a crossover trial means you enroll everybody. Some people are taking placebo, some people are taking the so-called active, and then they cross over. So if they start out on the NR or NAD, they would end up on placebo. If they start out on placebo, they're going to end up on the active that you're testing. And the people were sort of like true believers, and they said, oh, no, it wouldn't be ethical to do that trial. From my point of view, it's not ethical to do it as a non-placebo-controlled trial. You're never going to change medicine if you don't do it as a placebo-controlled trial. Because if the person has to lay out like $10,000 to do a treatment, and they have a very caring nurse, and treatment team, they may believe that this had value to them, but you need to demonstrate that scientifically, right? So, but to get back to your earlier question.
But it's a really good point, though, by the way. I mean, I think a lot of people talk about IV NR and NAD for drug recovery, but there has not been a placebo-controlled trial. So it's hard to say 100% certain this is working. Anecdotally, however, a lot of people use this all the time. I mean, I live in Malibu. There's like a recovery center. Every other house is a recovery center. And it's a massive use of IV to help people get off alcohol, opiates, all all of it. Right?
So you and I both hope that those trials are done.
Right. They need to be done.
But then what about niacin? What about nicotinamide? What about NMN, right? So NAD itself and NADP have too many phosphates. NMN has too many as a phosphate, right?
NMN does have a phosphate group on it.
So it doesn't go into cells. And there was a claim that a particular molecule is an NMN transporter. It's not an NMN transporter. It's a sodium transporter. We've done the experiments, and NMN has to be degraded back to NR before it can get into cells. Then it gets converted into NMN and NAD inside the cells. So like a chemist has to go to the trouble of putting the phosphate group on, then someone takes it orally, the phosphate group comes off. So it sort of doesn't make any sense. The other problem with it is that there's something called the DSHEA Act, DSHEA. DS stands for dietary supplement, right? And the DSHEA Act basically said that if something is a food or supplement and it enters the food supply as a new dietary ingredient, yes, you can test it as a drug, right? So niacin, has been in the food supply since the 1940s. In the 1970s or something, people started testing it as a drug, like high-dose niacin for lipids, right? That's legal. Still available as a as a supplement,
Sure.
still in food.
Got it.
But if something is introduced and tested as a drug, you can't sell it as a supplement, right? Because
see.
otherwise you'd be busting everybody's patents.
Yes.
And also you'd be taking things that don't go through the safety process that drugs need to go through. Plus, most drugs, 99% of drug candidates fail.
Right.
Right?
Right.
Okay. So what happened with NMN, right? So what happened with NMN is that NR is, discovered as a vitamin, and then there's a number of remarkable things done with mice, and then it's introduced as a human dietary ingredient. Chromadex, makes a business out of it. And full disclosure, I'm their chief scientific advisor. NMN comes along, right, and basically becomes popularized.
Right.
And people say, oh, yeah, you could take NR or you could take NMN. The most widely read book on longevity in the world, right?
Yeah.
There's a particular page number where the person says, oh, I take NMN, I take rapamycin, I take metformin, I take a bunch of other things that don't really make any sense. And so there's a market suddenly for NMN, right? But the problem is that a company already started testing it as a drug. So that basically means that anybody that is still selling NMN as a drug isn't going through the safety testing. It's not legal in the U.S., but it also doesn't really make biological sense because, again, the phosphate has to come off. So I kind of wish the science communicators would just say, look, if there is a use case for NAD boosting, which we just explained what it is, anti-inflammation, there's actually a safety-tested form of NAD boosting, which is NR.
Right.
In addition, there's nicotinamide, which is available.
Right.
There's nicotinic acid, which is available. It causes flushing.
The flushing is a problem, right?
Causes flushing. Nicotinamide and nicotinic acid don't have quite the advantage of NR because, and we were talking about this before the podcast, there's many of these conditions of metabolic stress where the NAD system comes under attack, and the NR kinase genes, so the genes that convert NR into NAD, they get upregulated.
Okay.
Right? So if you're taking regular nicotinamide or nicotinic acid, they don't go through that pathway. Not every single cell in the body can convert nicotinic acid into NAD.
Got it.
As far as we can tell, every cell can convert nicotinamide, and every cell can convert NR into NAD. And the NR has the advantage of fewer different steps to making all the way to NAD, and the pathway gets boosted up in a number of conditions. So like in heart failure, like in a mouse model of heart failure, nicotinamide doesn't work, whereas NR does, because it's the NR genes that are, the NR responsive genes are getting upregulated. And so it's the failing heart is looking for NR. So I would say if somebody is going to the trouble to boost their NAD, NR is kind of the more high value, precursor. NMN is going through the same pathway actually, because the phosphate has to come off and then it's NR.
Right, exactly.
But the problem is that 9 out of 10 products that are sold as NMN are not NMN.
For sure. That's the other problem.
And it's been revealed that many of them contain endotoxin and other things that are not safe. So it's better to
So that's interesting. Okay, so I think the supplement to drug versus drug to supplement problem is, it seems like such an arbitrary way to define what's a drug and what's a supplement, right? In the case of NAD boosters especially. And so NMN, was it Metro Biosciences that was testing it as a drug? Is that the
Metro Biotech?
Biotech,
has a patent on a crystal form of NMN.
Got it.
And potentially some use patents of like trying to treat a disease with NMN and so forth. So they started doing their investigational new drug testing, and then the FDA learned that they can't approve NMN as a dietary ingredient because it's already being tested as a drug.
Right, right.
So
So
that's the
everyone had
basis
to
of it.
stop selling it online, and
And if they didn't stop, then it means that they're willing to do a type of business where their stuff is not being, tested. Yeah.
right,
So
absolutely. And this is the
it's a
Wild
problem.
West of the supplement market. Is
Yeah.
you have, like you said, you're selling the supplement. It's not being tested just because you want to stay under the radar anyway.
Yeah.
And then there's endotoxin. There's sawdust in the bottle. You don't know what's in the bottle, right?
Yeah.
And so that's the problem. Whereas regular supplements, like let's just use vitamin D3K2 as an example. The companies that make this legitimately are doing third-party testing.
Yes.
And they rely on their reputation and the third-party testing to sell us these supplements. I'm a physician, and so I prescribe these supplements to my patients from certain companies I know that are third-party testing and doing this in a legitimate fashion. But you can't have that with NMN because everyone's doing it under the radar.
Right.
Right.
So for your clients, your patients, for NAD boosting, it's got to be niacin, right?
Right.
Yeah.
We use niacin because number one, the testing and the research behind it is solid.
Yeah.
And so, that's why I wanted to have you on because you created the product basically. And I wanted to talk to you more about that. But I think it's really important to clarify these points with people because, when you talk about NAD, you talk about NAD. Then you look up NAD and then you see NR, you see niacin, you see all the whole menu, and then no one knows what to choose. And these are the reasons I wanted to have you on, so people understand why I make the choice of choosing NR for my patients.
Right.
Now, there's also NAD that people can take, right? And some of this has been tested, but also with these products too, they have that phosphate group, which makes them less available inside the cell where they're needed, right?
Right.
Absorption is slow. There's less of it in the cell. And, the research that's been done by Chromadex is pretty convincing that the intracellular amount of ATP and NAD is much higher by taking NR, right?
Yeah. Right.
So these are all the reasons why. Well, let's separate oral versus IV. I think this is important too.
Yeah.
So orally, it seems like taking oral nicotinamide riboside would be the most bang for your buck, right?
Yeah, I mean that's actually where most of the research is. So, the original consumer dose of Niagen NR was 300 milligrams,
right?
But clinical trials have been largely done from 1 to 2 grams per day, right? And so, and I think that when the New England Patriots started, taking NR, I mean, they're guys in their 20s, although there was a quarterback who was 40, right?
Yeah.
They're taking a gram a day, right? So, so people that are looking for those types of results of, preserving walking speed for peripheral artery disease or anti-inflammation, probably were taking like three pills or something. So at this point, there's a True Niagen Pro or something that is a gram dose.
Right. I use a gram dose myself personally, but what I found is starting with a lower dose for some people is better because, there's so much effect that some people, they feel really amped up or they can't sleep. And so there's a little bit of, I have to meter it in on certain people, Yeah. So the bigger the person, I start a little bit higher, but sometimes I do use a 300 milligram dose if they're a smaller person.
Right? For me, it's not a stimulant. It's
absolutely.
The thing that almost everybody notices is that their fingernails and hair grow
faster, right?
Right.
Yeah.
So that's a little bit of an anabolic piece of it. That's not been clinically proven. But I think that would be demonstrable, in a clinical trial. It's a very obvious effect.
Something that needs to be studied as well. We keep talking about the need to be studied here, and I think it's important to discuss why all of this hasn't been studied. And I think it's because there's not $1 billion pharmaceutical company at the back end of this funding massive studies, right? And so a lot of these studies are being done onesie-twosies by curious scientists, right?
Yeah.
And I'm so glad that there are scientists willing to do studies such as the peripheral artery disease study. I mean, that's fantastic, right?
Yeah.
I've seen a lot of studies with nicotinamide riboside, or maybe they're case reports around COVID. I've seen some.
Yeah.
And I'd love to talk about the efficacy of these molecules in infectious diseases.
Yeah. So, in 2000, March 2000, I was teaching my biochemistry class, and everybody's reading the news, and I started giving a couple of lectures online because people didn't want to be in the lecture hall, and then of course the governor of the state of Iowa, where I was at the time, said don't go to class anymore, and I'm sure the same thing happened here. But we were able to keep on working in the lab because we wanted to see what was the effect on the NAD system of coronavirus infection.
Right.
And in fact, we were on the fourth floor of a particular building at the University of Iowa campus where one of the world's experts on coronaviruses was on the third floor.
Oh, that's fantastic.
And we had actually done an experiment a couple of years earlier with a mouse coronavirus. And we had the data, in our notebooks, and we had the samples in our freezer.
Wow.
And we kind of reanalyzed those samples, and we said, guess what? Double-stranded RNA viruses attack the NAD system.
Interesting.
And then we looked at the gene expression consequences of that, and it turns out that they activate these enzymes called PARPs, and they cause an innate immune response. So the same kind of innate immune response against intact mitochondria or NAD, there's an innate immune response against double-stranded RNA because it's considered like a foreign substance, right? And so the PARPs get activated, NAD goes down, and then we did an experiment to see whether NR would protect against infection. We got a very strong result.
Interesting.
And we published that paper in the end of 2020. And then since then, there are a number of groups that tested NR as either a monotherapy or as a combination therapy with like 3 other over-the-counter molecules. And essentially all of these studies have shown that NR accelerates time to recovery from COVID. So we predicted that it would help resist infection, and then others showed clinically that in combination with other non-toxic molecules, it accelerates recovery.
Right.
So there's some long COVID studies, I think, that are going to be coming out, and there's some kind of renal protection, kidney protection studies that are going to be coming out. So, it has some value in that space.
Yeah, I totally agree. And, now whenever someone calls me, Dr. Shah, I think I'm coming down with something, the first thing I do is have them start taking some NR supplementation, because I think it really, like you said, it cuts down on their time that they're feeling not so well. Can we talk about, let's talk about cognitive disease and also enhancing mental performance and using nicotinamide riboside. Have there been any studies around that?
There's no real data on, improving mental. I mean, I think that there's a signal for improved cerebral blood flow in mild cognitive impairment. And there seemed to be some improvement in a Parkinson's study.
Okay.
And the results in Parkinson's were done in Norway in a small study, and they were strong enough that the Norwegian government, funded a much larger study, which I think is going to be completing and unblinded sometime later in this calendar year of 2025. So we're looking forward to more data. But I mean, I don't like to bullshit people and say it's great for everything, but But I mean, the thing about niacin NR is that we know it's safe, and so the clinical trials are being done.
Yeah. I appreciate you saying that, because one thing I know about you, you're not a BSer, and so I love that you have data behind everything that you say. But I will say these are relatively simple studies, I would think, to be done, especially for mental performance.
Yeah.
You could just do a double-blinded study where you give someone placebo versus NR and do a cognitive assessment test, right? And so hopefully someone does those studies.
Yeah.
But I'm hopeful because I find myself, for example, podcasting is very mentally demanding, right? And so I definitely feel a difference on the days that I do my NAD or NR versus not, And I say NAD versus NR, it just depends on what's available, because I like to do it IV. And sometimes IV NAD has been available for a while. IV nicotinamide riboside just came out a few months ago, and I've been super impressed with the ease that we can do that, specifically because it does absorb quicker. There's less side effect during the absorption process. And it's a good time to touch on this, by the way, about the different delivery mechanisms, right? Because we've touched on oral, which we know there's a benefit to taking oral nicotinamide riboside, better absorption, IV as well, right? Between NAD and NR orally, IV.
So there are some mouse studies that show that there's some improved tissue availability, IV. As I said earlier, the failing heart benefits from oral nicotinamide riboside.
Right.
There are groups that claim that oral nicotinamide riboside is totally disassembled in the liver, but I don't know how they explain the results that have been obtained where oral NR was available both to the cardiac tissue as well as to skeletal muscle. So, I don't know what is the absolute percentage of oral NR that is available to cardiac and skeletal muscle, but it is, qualitatively available.
Right.
Can it be optimized potentially with intravenous? Yes, potentially. But that's an area where it's going to be, clinical trials that will be required to demonstrate
Exactly. And just for people listening, when you take something orally, obviously it goes into your gut, it gets absorbed through your gut into your liver processes it, and whatever is left is what's available. And that's why IV therapy is considered bypasses that whole mechanism, right?
Yeah.
What about giving it intramuscularly?
I think people have done it, but I don't know of, clinical data. I don't know of the ultimate data on that.
Yeah. And then finally, there's transdermal patches now too.
That I don't know anything about. Yeah.
So I think in the world of supplementation, there's lots of ways that people are trying to sell this stuff to people. And to your point, there's not a lot of data around what is actually bioavailable and what's happening. The only studies I've seen are oral and IV, right? It's very interesting. Any other potential uses of NR that you see or that you're hopeful could work out in the data in the future?
Yeah, so I'd love to see wound healing trial.
Yes.
I would love to see a fatty liver trial.
Yeah.
There was a little bit of a signal for that. I have to admit that early on, some of the clinical trialists were kind of high on hopium, right? of thinking that NR is going to improve, insulin sensitivity and cause weight loss in 12 weeks with no lifestyle modification. And that trial is going to fail, right?
Of course.
If you take 70-year-olds obese type 2 diabetic Norwegian, were they Norwegian or were they from Denmark? I think they were from Denmark. There were 70-year-old obese type 2 diabetic men in Denmark, right? They haven't played hockey in 30, 40 years, right? They smoke, they overeat, they don't get terribly much exercise, and you just give them a supplement for 12 or 13 weeks, you're not going to improve their insulin sensitivity, right? They're not going to lose weight. It's not magic, right? Well, GLP-1, yeah, you might get a signal in 12 weeks. You're certainly going to get a signal in 26 weeks. But GLP-1, injections cause people to eat less.
Yes.
Right?
Yes.
So that is the equivalent of calorie restriction.
Right.
It's a pharmaceutical, imposed way to get a person to follow through on their intention to eat less.
Exactly.
Right?
Yeah. It's creating a lifestyle change by force.
Yeah. I mean, while also doing other things to like slow gastric release and other things. So that will cause weight loss. But taking a vitamin is not going to. But if you look at that trial, that original trial that was done in Denmark, and you look at the data on the fatty liver, the men that had the fattiest liver that were on NR had a reduction in their liver fat. Huh. Now, the problem is it wasn't randomized for that, right? Yeah. So it wasn't randomized for that, so it got to like a P of 0.13, which means it probably was not by chance. It was probably a real result. But you really have to take the people in and say this is intentionally a fatty liver trial.
Right.
They're all starting out at, let's say, 0.2 or 20% liver fat, and you're going to do it for 26 weeks, which is the way a pharma company would do it, and then you're going to follow that as a primary endpoint. Because the problem is if you do these exploratory endpoints, right? For every 20 exploratory endpoints, you might get lucky and have a P.05 result, right? But if you pre-specify your primary endpoints, you can't cheat. You either made your endpoint or you didn't make your endpoint. Yeah. So now we're getting smarter about trials, and we want to encourage people to do trials where NR can actually work. Plus, exercise should probably be a standard of care. Right?
Absolutely.
If people have overweight and fatty liver, then something like exercise or GLP-1 is probably the standard of care now.
Right.
Then you can see, does NR improve on top of that?
Sure.
Right?
Yeah, you add the standard of care in as well. Right. Absolutely. Is there a use for NR you mentioned fatty liver disease. I think there's, like you said, there's a signal there.
Yeah.
What about in cancer, for example? How do you think about NR usage in patients that have diagnosed cancer?
So the original idea was that it may protect people against chemotherapeutic neuropathy.
Okay.
Because chemoneuropathy specifically attacks the NAD system. And so as a collateral effect of like vincristine type things, which attack the microtubules, the longest cells in our body are cells that kind of start at the sciatic nerve and go to the tips of your fingertips or the tips of your toes, right? So the people that have chemotherapeutic neuropathy have kind of a stocking and glove neuropathy, right? So the idea is that NR might protect them from neuropathy. To my knowledge, the trials have not been completed that have set out to test that. NR has been very active in animal models of chemotherapeutic neuropathy and has not simultaneously driven the cancer, right? What you would predict is that NR would help with DNA repair, and so, for example, nicotinamide is cancer preventative in a large Australian trial of skin cancer prevention.
Really? Okay.
And so, of course, it's ask your doctor situation, right? So I don't think it's going to be used as like a cancer treatment, but it could be used as an adjuvant to protect against chemobrain or chemoneuropathy.
Oh, that's fantastic. And then what about we talked about cardiac disease, we talked about heart failure, but what about in cases of just prevention for heart disease in the future?
Yeah, I think that's a big thing. There's a group at University of Washington that has been doing the heart failure stuff, and but almost every kind of heart disturbance disturbs the cardiac NAD system, and so it's probably a very heart healthy and liver healthy supplement.
Yeah. So I think with all these varied effects, potential varied effects, and some proven effects, I use it as more of a foundational type of supplement with my patients. And so, I mean, with every patient, they're all an N of one as far as their tolerance to supplementation.
Yeah.
Some say no supplements at all. I want to get it all from diet, and I respect that choice.
Yeah.
Some say, I'll take a few, but only the foundational ones.
Yeah.
And then some will say, I want to take a few more. I'll take some things that might help, as long as they don't harm me.
Yeah.
And then there's people that are like, give me everything that Brian Johnson and, every
Ray
single
Kurzweil,
person.
right.
Exactly.
Which is polypharmacy and probably stressing their liver and kidney, right?
Exactly. So, I try to get people to be somewhere in the middle, and then I take a look at all the supplements out there and I say, where would I put this in those 4 categories, right? And so I think NR supplementation is definitely coming more towards, for me clinically as a physician, talking to patients about what supplements to take. This seems one that, because it's safe, because there's so many varied effects, I put it more in that bucket of more foundational, right? So if someone's going to take they have low vitamin D levels, I give them vitamin D3K2, an omega supplement, and then this is one that I put in that bucket of those supplements. Creatine is also one that I'm a big fan of. So that's just how I use it. I don't think that necessarily applies to everybody, and not many physicians might disagree with me. But what I've seen treating thousands of people, I feel that's where I put it in, and especially if someone is ill at this moment with a viral or even bacterial, going through surgery, for example. Those are all use cases that I find helpful. Speaking of side effects, you've seen all the studies. What are some of the reported side effects of NR?
I haven't, they don't, I've heard of people that feel agitated or something like that, but it's not come up in the peer-reviewed literature.
Right.
So when you do placebo-controlled trials and you record adverse events, right? Somebody has a bellyache or a headache or something like that, and it's recorded, but then when you add up all of the data, you either see an excess in the NR group or you don't. And to my awareness, I haven't seen NR dependent adverse events in any of the trials. It's been essentially perfectly safe. So,
and that's my.
But there may be a person out there for whom it causes some type of agitation.
Right.
Don't do it. But it's not come up.
Dose, right?
It's not come up in the literature, to my knowledge.
That's fantastic. Well, great. I mean, I think this is a great review of the whole NAD, NR system, potential uses. There's a lot of science that needs to be done, as we both talked about, and I'm excited for all of it because, there's not a lot of molecules out there that can have so many beneficial effects across so many different potential use cases, and that's because every cell in our body needs NAD, right?
Yeah, this is true.
Absolutely. Can we zoom out and talk about the longevity field a little bit more, if you don't mind?
Yeah.
So, there's many other molecules that people are talking about. I know you're a curious individual and you probably read a lot of these. What's your take on some of the other molecules that people are talking about right now? Rapamycin, metformin. Would you give me some of your thoughts on those?
So I'd be more likely to take leucine than rapamycin. Okay.
Yeah.
So you know why I said that. So I mean, rapamycin is an inhibitor of the mTOR pathway.
Yes.
If you're a mouse, it's great.
Right.
Okay. But mice don't die of falls.
Right.
Right. People die of falls.
Right.
And healthy aging requires maintenance of skeletal muscle mass. I'm 63 years old. Yep. Okay. I have a
You look great for 63.
Thank you. I have a 44-year-old, wife, and I have 2 stepsons. The wife is a marathon runner, so and 2 dogs. So I chase a lot of people and dogs around. And So I want to maintain my skeletal muscle mass. I don't want an inhibitor of mTOR in my diet. And so to me, rapamycin is something for a transplant patient, and I wouldn't think it would be indicated for healthy aging. Would I like to see a clinical trial of it? Fine. Would I advise anybody related to me to volunteer for it? No. I think it's going to fail in human. I've looked at the package insert or whatever it's called, where it has the long list of adverse events, and it's real stuff. I mean, infection, cancer, and other things that could be associated with it. So I don't. Even though it's great in for mice, I don't think that mice are the world's greatest model for human aging. Metformin is something that has 15 different mechanisms of action, 2 or 3 of which inhibit mitochondrial functions, right? It's beneficial in type 2 diabetes. Yes, people with type 2 diabetes, have longer lifespans if they're on metformin versus other types of medicines, although those other medicines didn't include GLP-1 classically. They were the older stuff. So do I like the trial design of the thing that was planned for metformin? Sure. I mean, I think it's interesting trial design, but ultimately, no, I don't think that that's going to turn into a longevity drug.
Right.
So I don't think that there is a longevity drug. I don't claim that NR is a longevity drug. Although as something that, is a demonstrably useful as an anti-inflammatory, it's like you said, it's one of the first things that you would give a person to sort of boost resiliency, right? If a person doesn't die of a virus, then it might have scored, as a component of their lifespan, but it's not a trial that you can set out to test it. So I think that, the most valuable thing that we have is exercise and lifestyle.
Absolutely.
And, trying to be, engaged mentally and with other people and have a purpose in life. I mean, I don't think that we can do better than that. In terms of like technology that has extended lifespan, I don't think I'm going out on a limb to say vaccination has been probably the biggest high-tech thing that we've had. I mean, it's actually 1796, if you want to go back to the original reason why it's called vaccination, which is from a cow, right? And Fleming, was it?
Fleming,
And but vaccination has contributed to extending, human life. And how does it work? You're getting exposed to antigens, so you're educating your immune system so that if you walk into Disneyland and people haven't taken their measles vaccine, you're probably not going to get measles if you've been vaccinated. But if we start, casting aspersions on, vaccination science and people start refusing measles vaccines and polio vaccines, we're going to have these scourge, pandemics that
like we're back in the 1920s again.
So I think that's the. But I don't actually see. I know that everybody wants an edge, and everybody wants, a concierge clinic like this beautiful one. But that you want to major in the majors, not major in the minors, right?
Absolutely.
So you want to, in the 167 hours of the week where you're not seeing the patient, you want them to be sleeping and working out and enjoying their life and all those things, right?
No, and that's what we always start with. It's so important to optimize along nutrition, lifestyle, stress management, sleep, exercise. And there's really no reason to come in for an IV drip of NR on a weekly basis if you're out there eating ultra-processed foods and sleeping 4 hours a night. It just doesn't make any sense. So, these are all things that are additive to a basis of good foundational behaviors. Absolutely. I'm curious about you, and you're a scientist, very well-regarded scientist, and you have a amazing laboratory at University of Southern California, right?
No, City of Hope.
Oh, City of Hope.
Yeah,
Okay,
yeah.
that's right. You're at City of Hope.
Yeah.
Can we talk about your laboratory and what
Sure.
you're studying now?
Yeah. So August of 2020, I was recruited away from University of Iowa. I was a biochemistry department chair, and City of Hope created a new department for me. It's called the Department of Diabetes and Cancer Metabolism. So about 2/3 of the research at City of Hope is cancer. About 1/3 is diabetes and metabolic diseases. And so we created this new kind of interface department. And what I really decided to work on in kind of my new initiative is fatty liver disease. So the technical name, as you know, is MASLD, right? It stands for metabolic dysfunction associated steatotic liver disease, which is fatty liver.
Fatty liver.
And we found it syndromically in a rare disease. So there's over 1 billion people on the planet that have MASLD.
Right.
Most are people with obesity. But there are people that are skinny that have fatty liver disease. And syndromically, so in a rare disease context, there are people that are really skinny that almost always have fatty liver disease.
Wow.
And so we started working on that disease. It's called citrin deficiency. And we have a paper that's in review right now where we think that we break open this disease, and we figured out what's happening in the people with this rare disease that is driving their liver to be always making fat and never burning fat.
Wow.
So even overnight, your body is burning glucose, burning glycogen, burning fat, right? But in their hepatocytes, they have these persistent lipid droplets. So they're constantly driving the synthesis of the fat, and they're blocking fatty acid oxidation. And they have an interesting set of food preferences as well, because they don't like sweets.
That's
and we
interesting.
figured out, it is interesting. And we figured out, we think why they don't like sweets. It's due to something called FGF21 and that is circulating at a high level. In the mouse model, we've shown that when you induce the mouse model of this disease, citrin deficiency, the mice have high levels of FGF21. And so in this rare disease, the liver is dysregulated and it's making a high level of FGF21, which is active in the brain, and it's also making the liver store fat. So now we have all sorts of ideas that are going to be for the specific disease of citrin deficiency, and then a larger population that has lean MASLD, and potentially common MASLD. And then we also have an idea of how can we get people to make more FGF21 with a small molecule. So those are all the things that are going on in our lab now.
Those are all huge problems, right? And so you kind of, by studying this rare disease, you hit upon molecules that could be helpful for massive problems.
Yeah, people may not realize this, but like 10% of breast cancer is hereditary, right? So 90% of breast cancer is not, it is genetic, but it's spontaneous mutations, right? Whereas there are certain families where people, are born with a BRCA1 mutation, right? But what a lot of people don't remember is that the BRCA1 mutation was found in men. It was in rare families where there was male breast cancer.
That's where they found it, right?
When you look for these rare presentations of a disease, it's going to have a disproportional, impact into understanding the mechanisms.
Right.
So that's why we thought a syndrome where people are very skinny but have fatty liver, that's going to have a really big insight into a big disproportional insight into the mechanisms of disease. And that's what we're really excited about.
That is exciting. It's a great model for research as well, too. Don't go looking for the needle in the haystack. Find something much smaller than a haystack. Well, congratulations on that.
All right, thank you.
When's that paper coming out?
It's in review, so hopefully reviewers will be excited by it. And but people can read it on on the bioarchives on my Twitter page. We have a link to it. Yeah.
Okay, great. And so with that, where can we find you? Where can we learn more?
Yeah.
I mean, obviously we have to keep up with you. You're coming up with some incredible science. So how do we keep up with you?
So there's a lab website. It's brennerlab.net.
Okay.
And people can ask me questions on Twitter. Charles M. Brenner. You have to use my middle initial M to find me. And then, I make the rounds on podcasts, and I'm going to be at University of Michigan next week. I was in New York City a couple weeks ago and doing seminars. But yeah, great.
She's from University of Michigan.
Fantastic.
Yeah, that's fantastic. Well, can't wait to have you on again. I feel like in a year from now, you're going to have even more incredible data to share with us and more incredible research. So thank you so much and for doing everything that you do. And thanks for joining me on the podcast.
Pleasure. Yeah. Thank you.
Thank you, Dr. Brenner.
Yep. Bye.